So, good afternoon, everyone. Thank you for joining us for what should be an interesting IC, and really, thank you for being here on the last day, right at the end of the conference. It's not easy. So, we'll be discussing something that is very relevant to all cataract surgeons and something that, especially in our part of the world, we deal with very frequently, and that is hard cataracts. Uh, there is no one perfect solution for hard cataracts, and our aim today is to discuss different approaches. Each surgeon usually tends to have one particular technique that they are more comfortable with, or one particular tool that they're more comfortable with. So today we have incredibly experienced surgeons who are present with us, and I am sure we will learn a lot from their experience. So to start off with, we have the youngest of us, Dr. Manik, who will be talking about a hard cataract versus a hard surgeon. That how should you go about preparing yourself for such a case?
Ju- At the outset, let me congratulate Dr. Manik Sardana for the Colonel Rangachari Award this year. Heartiest congratulations.
Thank you, sir, and thank you, Dr. Sataj, for the nice introduction. So I'll straight away start with my presentation. So I was given this topic, hard cataract versus hard surgeon. So what I got off from the topic is that even if you don't have any special instruments, how to go about for preparing about the surgery and how to go about the surgery. So dense cataract poses certain challenges like the risk of endothelial damage, there is zonular stress because of the hard cataract, there is risk of posterior capsular rupture because of lack of any epinuclear shell, and the rock hard nucleus itself, in which the posterior thick plate is difficult to divide. So preoperative assessment forms a important part of the planning, and we should always grade all the cataracts according to the LOX 3 classification. We should look for certain warning signs like phacodonesis, asymmetric anterior chamber depth, pseudoexfoliation, and a preoperative endothelial count, as well as a thorough assessment of posterior segment along with USGB scan whenever needed is important. So coming to certain steps, always stain when you have a poor red glow in cases of hard cataract, and in cases of an intumescent cataract with a dense nucleus, always pressurize the anterior chamber so that there is no rexus runout and prevention of Argentinian flag sign. Always perform a multi-quadrant hydrodissection so as to free the corticocapsular adhesions from all the quadrants. And the core strategy for nuclear division is space creation. So always make a wider groove at a particular depth so that there is space for pulling the nuclear fragments easily. And whenever you pull the first fragment, then there is space creation, which will be coming in subsequent videos. And be at a posterior plane for phacoemulsification so as to prevent the endothelial damage. Any vertical or horizontal chop, whichever you are comfortable with, is good, but yes, vertical chop maneuvers are better for extremely dense cataracts. Many alternative techniques have been devised for especially for hard cataracts like tilt and cracked, drill and chop, and flax and MI loop will be discussed in subsequent presentations. So protection of endothelium during surgery is of paramount importance, and there are certain ways that you can go about it. So first, any dispersive OVD to coat the endothelium is important, like chondroitin sulfate, and always perform a posterior phacoemulsification in the bag or at the level of iris plane. Do not come anterior. Use your chopper in the second instrument to protect any deflection of the sharp fragments for touching the cornea, and always refill viscoelastic in between surgery whenever you feel the need for it. There are certain phaco power modulations also to prevent endothelial damage, like pulse or burst mode, where the micropulses, the off time between the micropulses allow the needle to physically cool down and prevent any endothelial damage and wound burns. The torsional ultrasound, if available in the phaco machines, definitely help because the side to side oscillatory movement provides seamless shearing rather than the longitudinal one. Another technique described is the IOL scaffold technique to prevent the posterior capsular rupture during hard cataract, especially while you are emulsifying the last piece. So inject the IOL first in the bag uh, before injecting viscoelastic, then emulsify the last piece above the IOL so that the posterior capsular and the bag is completely secured. So I'll just share two of my videos for hard cataract. Hopefully they'll show something for you to learn. So superior main paracentesis is made, then continuous curvilinear capsular access is initiated. A well-centered 5 mm capsular access is mandatory. As discussed, a multi-quadrant hydrodissection is performed. Then a dispersive OVD is injected into the anterior chamber. A central trench is made to debulk the nucleus. Then a mechanical chop maneuver is performed to divide the nucleus into two heminuclei. Then the nucleus is further divided into smaller pieces for better phacoemulsification. Again, in nucleus is holded, a horizontal chop maneuver is performed and the nucleus is divided. Further sub-chops are done to avoid any damage to the endothelium and to provide for better phacoemulsification. Cortex aspiration is completed. And then the planned toric intraocular lens is implanted into the bag. So this is the final picture, and the patient did extremely well after the surgery. So this is another case where it's a case of pseudo exfoliation with a very hard cataract, and the other eye surgery was done elsewhere, and it was a complicated surgery. Posterior capsular rupture had happened, then the patient developed retinal detachment, so the patient came here for the other eye surgery. So after making the main incision, the capsule was previously stained with trypan blue dye. And then a continuous curvilinear capsular access is made. A dispersive high molecular weight OVD is injected into the anterior chamber. Then again, a horizontal chop maneuver is done to divide the nucleus into two heminuclei. So here, divide the nucleus into multiple small pieces, and once you take out the first piece, then the job will be further easy. So yes, here divide and take a small piece out of the bag so that there is now space in the bag for manipulation and working. Further sub chops are done. Then a planned 3-piece intraocular lens is placed in the bag and the ports are hydrated. So at the end, I would just like to mention a few points which you should take care while working on hard cataracts. So always stain whenever you feel the need of it. In an intumescent lens, always over pressurize the anterior chamber with OVD. Hydrodissect in multiple quadrants, create space in the center and debulk the central nucleus for easier manipulation, chop into multiple small pieces and modulate power. With the newer machines we have multiple options to modulate power so as to prevent any further endothelial damage. Thank you.
Thank you, Dr. Manik. I think that was an excellent talk and wonderful surgical videos. which really showed sort of all the key pearls for hard cataracts. Uh, just one question that I would have really quickly is, so in all hard cataracts, will you proceed and do a hydrodissection, or are there certain situations where you would maybe prefer to avoid it?
So yes, if it's a white intumescent cataract, we'll try to avoid the hydrodissection, as the cortex is already liquefied and we actually don't need to perform any hydrodissection because the nucleus is already free once you get out. But
Thank you.
otherwise, yes, in dense brunescent cataracts, do a multi-quadrant hydrodissection and so as to free the cortex.
Thank you. So next we have Professor Jagatram Padamshri. He needs no introduction. He was the director at PGI for many years, and now he heads our cornea and cataract services at Garewala Institute. Sir is, one of the greatest cataract surgeons of the generation, and here we have him sharing his experience to talk about how to crack the hardest ones, pearls of wisdom.
First of all, I am thankful to Dr. Sartaj and Dr. SPS Grewal for giving me this opportunity to speak on hard cataract. I will be speaking how to crack the hardest one. What are the challenges in performing phaco on black or brunescent cataract? One of the issue is capsular axis may be difficult to perform because there may be no red glow. So most of the time we have to stain the anterior capsule with trypan blue dye. High energy is required to emulsify the cataract, and this will there will be much more chances of damaging the corneal endothelium. Leathery cataract, they resist fragmentation due to chopping. Higher chances of posterior capsular tear. Zonular stress and subluxation, more chances. Increase chances of iris chafing. We have to make decision whether we are comfortable in doing phacoemulsification, small incision cataract surgery, or phacoemulsification. So these are some of the we have to, as already said, endothelial cell count, wherever required, bag stability, preoperative ultrasound to rule out retinal pathology, type of IOL, sometimes we have to keep with us even 3-piece IOL. Pupillary dilatation is very, very important, and of course informed consent from all these patients. Yeah, this is one of the case where not extremely hard, but during surgery we found that it was quite hard. Look maybe just brownish, but while we perform such surgery we have to do it very, very carefully. We have to make adequately deep trench. And then try to divide it. think once it divide, one become much more confident, and once you take a small piece out, there will be much more space, and it will be easy to chop and emulsify. Then removal of the cortex from the capsular bag. In many of these hard cataract, there may be less cortical material. Then ultimately placement of hydrophobic acrylic IOL into capsular bag. This is another look. Maybe it may look simple, but it is just white and black cataract. You just see extremely while doing this, we realized that this was very hard cataract. Although we expected also that this is a brown cataract. Adequate size rexis is quite important. Then, as Dr. Manik also said, multi-quadrant hydrodissection. Of course, sometime in the swollen cataract there may be it is already emulsive. It is already easy to rotate without much hydrodissection. And then multi-quadrant, multiple pieces you make from of these hard cataract, and removal of the cortex become easy in these patients. And if there is no red glow, I think we have to stain the capsule with trypan blue dye, and many times we have to put repeated viscoelastic substance. We have to change the phaco power setting, and also the vacuum and other setting. And this is again hard cataract. Direct chop failed, but then you have to make a good groove, and then we become successful once I think it is a deep. This is a white cataract, but it was found to be quite hard while performing surgery. We have to make multiple fracture of the nucleus. Then you may see absolutely jet black cataract where there may be no red glow. So here these are the patient which may need trypan blue dye for staining the anterior capsule. And I think these patient, despite using phaco power of 75 to 80 and doing whatever, I think direct chop, or you may do stop and chop. When we make the trench first and then chop, that is stop and chop, or you may do direct chop. It is I think you should have patience and put viscoelastic repeatedly into anterior chamber to coat the endothelium, and quite hard cataract, more emulsification in the anterior chamber, more corneal edema will be there in the postoperative period. And here I think we have to have lot of patience. It is not immediately, it cannot be done because it takes time for such a very hard cataract to emulsify. So patience is the key to success. Of course, femtosecond and my loop and other these are there, but I will show some of the just one clip of femtosecond. Though Dr. Grewal will be showing this in detail. Many time or most of the time, it make life easier if you do femtosecond. In these cases, because Rexis is very easy to do, and then chopping also become easier. This is a quite hard cataract, and so if it is available, this modality of femtosecond, then I think it should be used wherever possible. And implantation of hydrophobic acrylic IOL, almost universal presently. There are several other situations, but I will go to some complication occurs. It is not always that one is successful. There may be corneal edema is one of the most common complication. There may be PCR or there may be Descemet's membrane detachment. This is one case where which look that I think it was quite all right. Nothing happened and nothing was found that what happened here. I was doing this case and I found that something is, something is happening. And there was a dislocation of the nucleus into vitreous cavity. This was so sudden and unexpected, because I could not see that this was a posterior polar cataract. Although excusing or making this allegation that it was a posterior polar cataract, that is fine. But here we should not try to follow the nucleus and take it with the wire practice. It is best that whatever anterior vitrectomy you do and implant IOL into capsular bag and place at least one suture in the main section, because retinal surgeon will do the vitrectomy. Same day vitrectomy surgeon was there and removed the nucleus, and patient achieved excellent vision. But one should not go and follow the. So in so take home message is that pre-operative assessment for density of cataract, dilatation of pupil, zonular stress and endothelial cell count, it is quite important. Staining of the anterior capsule using trypane blue dye, larger rexis and adequate hydrodissection and rotation of the nucleus. Because later on nothing may happen, I think rotation is quite important. Keep using viscoelastic dispersive type to protect endothelium. Always have a backup plan, CTR, pupil expanding devices, and 3-piece IOL sometime required. And lastly, do not lose your patience. Patience is most important, and don't have ego that you cannot convert it into small incision cataract surgery or ECC. Sometime it happens, so I think no ego should be there. So I think it was pleasure to work with Dr. Grewal in Grewal Eye Center. Thank you very much.
Thank you so much, sir, for those excellent surgical videos showing what is pretty much the extremes of phacoemulsification and hard cataracts. Really, the points that you made, have a very low threshold to stain the capsule. That is excellent, because and also to always be prepared for the worst, that you don't really know what is lying behind that really dense cataract. As you said, it can be a posterior polar cataract that you can't see, and so you always have to have a very high level of attention when you're doing these kind of cases. And also the note at the end of complications, that it's not the end of the world. Even if you have a complication, relax, have a good backup plan, always do what is in the best interest for the patient, communicate very well with the patient. And today, any kind of complication can still be salvaged, and you can still have the patient have very good vision at the end.
I agree with this that counseling is very, very important in these hard cataract. We should tell before surgery that what is the expected outcome and how long it will take to clear the cornea. Because if you say that first day you will be 6 by 6, that is not possible. So we expect many times, even despite doing femtosecond cataract surgery, that some corneal edema may happen, and we tell them that okay, you will be fine like that, but majority of the time patient 99% will be fine, but these complications such as corneal edema is the commonest. There may be, I think, PCR and some other Descemet membrane detachment, several complications, iris chafing, this occurs.
True. But
Thank
again,
you so much.
timely diagnosis and referral can always help ensure a good outcome in these patients.
Yeah.
So thank you so much, sir. So we'll have the next speaker will be Dr. SPS Garewal to talk about flax is still relevant for Brunison cataracts. So Dr. SPS Garewal is again a cataract surgeon at Garewal Institute, the founder, and he particularly has a great interest in newer technologies, and presently actually his entire cataract practice is only flax. So I don't think there can be anyone with more experience on flax, and especially how it can be deployed in these very dense cataracts. Over to you, sir.
Thank you, Dr. Taj, and all thanks to all the instructors here who have put a lot of pains for this, and my special thanks to the audience to be here with us in the last moments of the conference on a Sunday when everyone is looking forward to go back home. So breaking the hard cataract is not only force. I think you can replace the force with intelligence, with planning, with resources to make it safer, more predictable for the patient with better visual outcomes and quicker visual outcomes. As has already been highlighted, that with dense nuclei, they often block the red reflex and make it difficult to visualize the capsule, which increases the risk of an incomplete or erratic rhexis. And it has been beautifully shown by Professor Jagatram that staining is a must, that you should stain it to see the. In older patients with hard cataract, the anterior capsule can be more brittle, or conversely, it can be lathery and difficult to shear with some of the fibrosis under it. Zonular stress is a real thing in these hard cataracts, and often they are associated with weak zonules, pseudo-exfoliation syndrome. So the mechanical manipulation required to rotate a large dense nucleus will have much more stress on the zonules, and one has to be aware of it all the time. Both nucleotomy and phacoemulsification in dense nuclei require significantly higher cumulative dissipated energy, which generates heat, and it can lead to corneal burns. It can also lead to higher chances of endothelial loss because of a combination of high ultrasound energy and the physical turbulence of sharp nuclear fragments, which can hit directly and mechanically damage the endothelium. Lathery posterior plate is a major hurdle in these cataracts, and even in flax, please remember you are leaving a 500 micron plate behind, which is still lathery. So flax is also not giving you two separate kind of a thing, but it makes the division into two fragments much more predictable and easier. And another thing is that the hard cataracts lack a soft epinuclear shell. There is no cushion. and there is not much space to work within that, so you should keep that also in mind when you are looking at hard cataracts. So this reduced working space is already there. Posterior capsule rupture risk is heightened, and one has to be prepared to handle these cases with an excellent pragmatic approach that Professor Jagatram has shown, and then let your posterior segment team chip in and take care of the rest. Now, when you are doing the flax in these cases, the settings will not be the same as it is for regular cataract. As you can see, that grayish thing coming in sheets, this occurs in hard cataracts only, because in between the lens fibers, they are so dense that the whatever gas is generated stays in that plane and doesn't move out into small bubbles like that you can see in the soft. So what difference are required in doing the settings of the flax? One is you reduce the spacing of the spot, you increase the energy, and you normally we will keep it at 3 pass, but for hard cataract I'll be putting it at 5 passes. So you need to change the settings of the flax machine for a hard cataract so that you are able to cut through the hard lens. So you have a good capsulotomy in all cases of hard cataract with flax, which to my mind is a huge advantage. Can you do direct chop in flax? Yes, but in hard cataract, no, because as I said, you need space, so you need to debulk and make a gutter and debulk it so that it gives you some space available to work within a tight hard nucleus. So it is important to debulk, and normally I'll go at least 1.5 width of the phaco tip slowly, and then you engage it and then try to chop. So you go into the, now this is where it makes all the difference. And if you see here, now did you see the red reflex throughout? Now this is one step where I will heave a sigh of relief that okay, I have divided into 2, now it is going to be more predictable. So I go to the first fragment, separate it out, and also shell it out from the epinucleus. Now this is shelling it out from the epinucleus, so that you pull the nucleus and push the shell back so that you separate or reduce the forces holding the fragment back, and after that you take away the fragment. If it comes completely, it is fine. Otherwise, since I know that I have already divided into 2 beyond the center of the nucleus, so I'll go to the next fragment, same thing again, chop, then separate it from the epicortex, and then slowly do it. And it's, if you see at this moment my focus is on 2 things. It is onto the phaco tip and the nucleus, and second is where I am placing the tip of the chopper. And I always keep the tip of the chopper in the path of rotation of these fragments, so that it kind of prevents the rotation of these fragments and holds them in place so that the phaco tip can eat away them easily. So it reduces the chances of chafing, it reduces the chances of the fragment moving around into the anterior chamber, and also reduces its chance of hitting the endothelium. So this is again separate it from the epinucleus, hold it back, pull the fragment, hold the epicortex back, sub-chop if the fragment is a little bigger, and then slowly eat it as far away from the endothelium as possible. So after dividing it into 2, for a softer cataract, I may divide it into 6 pieces to begin with before I take away the first piece. But, but in a hard cataract, I would prefer to take out 1 piece that also gives you space to rotate the nucleus, that also gives you separation more, it also gives you more space to separate the next fragment, and then removing the epicortex, flipping it, and once it is flipped, then the The phaco machine does the rest of the things, and it's great to work on machines with stable anterior chamber and excellent fluidics, and most of the newer machines are able to give us very good fluidics. This is again another case, and setting of the flax again, which are set to a hard cataract. You can make the capsulotomy to 5.5. Normally we'll keep it at 5.1. You have higher number of passes. You increase the energy, have a shorter spacing between them. And since you are doing 5 passes, it is little longer that is going to take. So you have to keep on talking to the patient so that it doesn't move during the process. And your each pass should go through the same plane where the first pass has gone. That will give you the best division. If the patient moves a little bit, then you get 2 different planes, and then your separation may become a little difficult. So again, making a trough, so that debulking, and then separating the first fragment. Now this is where the flax gives you a huge added advantage, because it's not separated, but there is already a nice cleavage, and it doesn't take much force to separate out it into 2 parts. And in hard cataract, the most difficult is your first breakage of what I'll say the spine of the nucleus and making into 2 parts, so that you can then do it. Now, so one fragment has been removed. So once a fragment has been removed, the rest is, as Professor Jagtaram said, is patience. This is important. Go slow. Go with the fluidics that you are understanding. Make sure that you leave behind the epinuclear plate as a protection, because in these cases, if you remove the epicortex and then you have half of the nucleus and the bare capsule lying, then again it becomes more difficult and challenging with higher risk of the complication. So it's important in these cases to create a cleavage between the nucleus and the epinucleus, and to save the epinuclear plate so that it acts as a scaffolding and reduces the risk of posterior capsular rupture. So after you have removed the first, then rest becomes you rotate, bring it forwards, eat, hold, sub-chop, depending upon how each fragment is behaving. You will have a slight change in way you are going to eat away that piece. And then my left instrument will always be there to prevent the rotation of these fragments. In these cases, it's important to remove the nucleus completely. In some cases, you will have very small fragments of the nucleus separating, and they may go into the angle, they may go behind the iris. So please remove completely the components of the nucleus before you go ahead. So the main advantage of flax is that capsular access. This is automated, precise, reproducible, predictable. Ultrasound power significantly less means that you'll have a clearer cornea next day, and patient will have recovery of vision much faster than it will be with manual. Zonal stress obviously is going to be minimal. Cost is worth it. Only thing is it's a 2-step procedure, but then there are huge advantages for it. This is a glimpses of our new premises at Chandigarh, and thank you so much.
Thank you so much, sir, for again an excellent talk, excellent surgical videos, and especially that summary at the end, which sort of tries to highlight the unique advantages that flax has. I think it's both ways. It is something that we can offer to our patients as something more premium, maybe more safe, especially for certain more challenging situations. But I think it's the other way around also, that sometimes patients have a preconceived notion that this is better. And sometimes we tend to shy away and not offer it in certain more challenging situations. But it's important to remember that these technologies do well and maybe even better in those challenging situations, so we should offer it to our patients. Anything about energy settings? Do you keep them different for softer cataracts, harder cataracts, and how do you deal with any chances of sort of any bubbles behind the nucleus?
Yeah, setting, as I mentioned, setting for a hard cataract and soft cataract are going to be different. It will be the spacing of the spots, it will be the energy level, and it will be the number of passes. As far as the chances of the bubbles and spots generated in hard cataracts, it is not there, because the nucleus is very dense, lamellae are very tight, and you don't have enough space for these gas bubbles to coalesce and form bigger bubbles. They'll be very small, and the moment you do the first cleavage, whatever it is, they'll come into the anterior chamber, you clean it out and proceed ahead with the surgery.
Thank you so much, sir. Dr. Manek, Dr. Jagatram, and Dr. SPS have a flight to catch, so they might leave a little early. Does anyone have any questions for them that we can take up while we are setting up? So next will be me, and I'll be talking about the MyLoop. Hello. So a quick show of hands, has anyone ever used MyLoop? Any experience with MyLoop? Wet lab, good, good. A show of hands, who has heard of MyLoop? Good, encouraging. So I will be talking about what is a relatively newer tool, something that was conceived especially for hard cataracts, and it was actually conceived as a part of a bigger vision of cataract surgery, which is not SICS, but which is also not ultrasound energy, not laser, and this is the first sort of step in that direction. I am a consultant for Carl Zeiss. So to start with, dense cataracts like these, again, these are something that we face quite often, and they are something that can give us, sleepless nights when we know that tomorrow morning we have to go into the OT and face this. And when you're in there inside the eye doing phaco, months can go by and you're still struggling with that leathery plate. It seems as if time has stood still. There's sweat pouring down your forehead, and you're just wondering, how do I get this out? It's challenging from start to finish. Because especially if you have a dense leathery plate, it just refuses to come apart, and phaco is based on that if you can nuclear disassembly is breaking it into smaller pieces and then taking it out very efficiently, and hard cataracts are just not amenable to that. So with the MyLoop, you have something that can go ahead and transect the hardest of nuclei, irrespective of the grade, with the same ease. And it is something that can divide it into 2, 4, or even more pieces consistently without any energy. So what is it? It's basically, it has a micro thin superelastic self-expanding filament made out of nitinol. It's 300 microns in diameter. And again, zero energy lens fragmentation for any grade of cataract. It has an anterior-posterior diameter of 10.5 millimeters and in height of about 5.5 millimeters, so it can engulf even the largest of nuclei that are out there. So I'll just briefly talk about how you get started with this, how do you use this instrument. So the first step is actually getting inside the eye, and that is one of the trickiest parts. You don't want to sort of align the shaft with the incision, you actually want to align the loop itself and first let that gently go in. So just try to lift up the upper lip of the incision, push down, and then gently go inside, and then sort of move the shaft towards the incision and go in. You want to make sure that you are opening it from the center of the nucleus and your capsular rhexis itself. And as you open it, make sure you rotate the MyLoop just a little bit so that the filament is brushing against the lens matter as you open it. That will increase the chances that you might go a little bit under the cortical matter, but you will definitely be below the capsule itself. Let it go and then gently start rotating, and it doesn't take a lot of force to do that rotation to get it behind the nucleus. If you feel it's taking more force, or if you see the whole bag is moving, then maybe you are above the rhexis. In that case, again, just withdraw, come out again. Once you go down, make sure you open it up completely, and you can actually see this sort of shiny reflex at the back, even no matter how hard the cataract is. Open it up completely, let it go to the middle. At that point, when it's in the middle, when it's sort of horizontal, you'll actually see that the two filaments are quite straight, and then just contract it. and no matter how hard the cataract it'll go, then it's very easy. Just rotate the lens matter again, rotate it as you would with in normal phaco, and again just deploy the filament, take it back again, and it's very easy to, again, no energy, and you have 4 equally divided pieces very easily. Now withdrawing it again is important. Make sure you pull it back completely, contract it, and again sort of in a reverse, that first incision and then towards the end angling it a little bit and getting the loop out too. So I will now discuss, interestingly, really, because with my loop, the density of the cataract is irrelevant. It's soft, it's hard, whatever it is, it'll cut it into pieces. So I'm actually going to talk about certain other uses of this particular device, and starting off with weak zonules, which is actually a contraindication to using this device. So this was a cataract, an 86-year-old lady, very dense cataract, and when I started the capsulorhexis, I could see that there was some phacodonesis, poorly dilating, so I used iris hooks. So I went ahead, and because of just the density of the cataract, I was very keen to use the MyLoop. And because of the zonules, I thought, okay, let me go in, let me see if I can use it. And it was actually divided it very easily. I was not keen to rotate or manipulate this nucleus too much, so I actually said, okay, one cut is enough, let me go in. And then when I started doing phaco, I actually realized it was rotating quite easily. So I stopped, came out, more viscoelastic, and went in again with the MyLoop to now divide it into 4 pieces. So that's the other thing, that even if there's a cataract that you started thinking that I'll be able to handle this, but you suddenly realize that, okay, this is much more dense than I was expecting, you can stop, go ahead, and deploy the MyLoop at that point again. Then after that, it's quite easy. You just go ahead, you have 4 pieces, pick them up, all what we have heard so far, cover the endothelium, keep the phaco at deeper level, and just gently, slowly keep taking these pieces out. So at this point, I put in a CTR to just help stabilize the bag. And interestingly, after that, just it's a routine cataract. So a dense cataract like this with weak zonules, where with phacoemulsification, you'd be stretching that bag, manipulating that bag, and weakening and compromising those zonules further. The MyLoop is actually an excellent alternative that you can use. Again, just very gently remove the cortical matter, and then implanting an IOL in the bag. So this was another situation where I started off just routine cataract, thinking it's not a very dense cataract. And as I was doing it, I realized, you can see sort of superiorly over here that the zonules are a little weaker. So I went ahead, put in a CTR at that point. And since I was still struggling to actually break up this, chop this nucleus, I actually, after putting the CTR, went ahead and used the MyLoop. And again, you could very easily, even with the CTR in there, weak zonules, you could very easily divide the cataract and then just go ahead and remove it, obviously keeping the bottle height a little lower. But it's a very versatile tool, and it's a great rescue tool for those situations that you were not expecting or anticipating at the beginning of surgery. Another very interesting use I found is small pupils. Now, if you have a very small pupil, you've done your capsulorhexis, and then the real challenge is really going in and dividing it into 2 pieces, because there's just not enough view to manipulate the chopper. That is where this is an incredible device, because you don't really need to be able to see everything. If you angle it down and let it brush against the cortical matter, you are certain to go below the capsule. You don't even need to do a hydrodissection in these cases if you're using the MyLoop, because as it goes behind and around the nucleus, it'll actually do the dissection for you. So many times when you do a hydrodissection in these cases, the iris prolapses and then you're stuck just handling the iris for the rest of the surgery. So this is an excellent alternative even for cases with IFIS. Again, corneal opacities, sometimes you'll have corneal opacity with dense cataracts. The advantage of the MyLoop tends to be that bright filament is very easy to see even when the cornea is poor and the reflex is not very good. So again, if you keep it pointed down, brush against the cortical matter as you're expanding it, you are very likely to get it into the correct plane, and again, go ahead and divide this nucleus very easily. Some people ask, what about posterior subcapsular cataracts? Again, dense cataract, sometimes they're so dense that you don't even see the posterior subcapsular part on the slit lamp preoperatively. So went ahead, did Capsulorhexis, and I decided to use the MyLoop. And much to my surprise, it was able to go ahead and dissect it. Again, because unlike hydrodissection, there's no pressure really being built up over here on that, let's say, on a plaque or on a weak thing. It's just gently going and dissecting them in that particular plane itself. So it actually works very well with even posterior subcapsular cataracts and a dense plaque. So briefly, there is some published literature out there, and it consistently shows that you will end up using a lot less energy if you're using a MyLoop in these dense cataracts. It showed, every step of the surgery, even time was down by about 37%. There were some other very interesting studies, one which actually showed that your refractive outcomes can actually improve in dense cataracts with the help of a MyLoop. And the postulated theory was that probably because you're putting less stress on the zonules, your ELP comes out to be closer to what you had calculated initially. And there was a very interesting study out of Arvind in very hypermature cataracts where they actually first put in and they did the Capsulorhexis, removed the liquid matter, put it in an IOL scaffold, and did the piggyback sort of MyLoop on top of that. And that is an excellent way to preserve the zonules in what will be already very weak and compromised eyes. And in all of these surgeries, all of these studies, the most impressive thing, and also in my personal experiences, I've never encountered a complication because of the MyLoop itself. If any of these surgeries did have a complication, it was maybe at the time of phacoemulsification itself, but never at the time of using the MyLoop itself. So to summarize, the advantages are it works in small pupils, poor corneas. You're not applying as much stress on the zonules because the force is all centripetal, not centrifugal. You're not stretching the bag in order to chop this. It's compatible with the CTR. So again, all those challenging situations that we face, this is a great device for all of them. You will achieve a complete nucleotomy. There'll be no strands or a leathery plate left behind as you have with flax. And studies have shown that you will end up using less energy, being gentler on the cornea, and also surgical time. And other than just surgical time being reduced, it's the consistency. Many times, if you've managed to chop it quickly, good, you go on to the next steps. But sometimes you're not able to do that and you're stuck there forever. With this device, it's consistent, it's predictable. And as phaco machines are becoming better, we are pushing the machines to the limits. We are doing cataract surgery in these harder cataracts. And these machines can leverage fluidics very well, which again mean we need to use slightly less energy. And with 4 pieces over there, you just have to go and pick them up. And some of these machines, they reach almost 700 millimeters of mercury with an absolute stable chamber. So all these technologies coming together are really allowing us to deliver a very premium experience, even in very challenging situations. Thank you.
Presentation and a magical way of doing it, and the videos are so impressive. I have one question: why not many people are still going towards MyLoop when it is much more economical than flax, and it cuts the nucleus in much easier and complete than the femtolaser does?
I think there are 2 reasons. Well, 3 if you include the commercial. Zeiss does not push this product very well. But it's getting better. At least some people were aware of it. Someone has tried it in the wet lab also, which is excellent. Second is cost. Even though it is less compared to a premium technology like flax, but still there is a unit cost. Every surgery you have to add the cost of that, and it has limited use. You can only use it 4 times. After that, the device gets locked down. So in our country, that is a factor that we have to keep in mind. So patients who can afford or patients who have insurance, there you can use it and it's great. Thirdly, the thing is, even though all the studies have shown no complications, it looks like an intimidating device to use. It doesn't appear to be that easy, but it is. There's no particular. The learning curve is very short because it's not like a phaco machine where you're learning how to chop first, where you're understanding the parameters of the machine. It's one little device. Just go in, rotate it, pull, and you're done. But I think there is, there's not enough people talking about it, and there's not enough awareness about it, and as a result, people have a lot of apprehensions about how it performs.
Thank you so much.
Thank you.
Now we move on to our next speaker, Dr. R.S. Dhariwal, and we have structured this instruction course in such a way that instead of everyone showing his own way of doing a hard cataract, we have tried to cover up the different techniques available with us in our armamentarium to handle these cases. And Dr. Dhariwal will be speaking on small incision cataract surgery, optimum for hard cataracts.
Thank you, sir. May I have my videos, please? Respected faculty, dear colleagues and friends, if there is one procedure in modern medicine that has undergone extraordinary refinement, it is cataract surgery. Over the past few decades, we have moved from large incisions and sutures to elegant micro-incisional techniques, rapid recovery and visual rehabilitation that often feels almost immediate to our patients. Phacoemulsification has led that transformation. It has redefined precision in cataract surgery, reduced surgical trauma, and elevated the patient expectations across the world. And more recently, Flax has added another layer of technological sophistication, laser-created capsulotomies, reproducible corneal incisions, and nucleus-free fragmentation designed to make phacoemulsification even more controlled. All this represents remarkable progress. And as surgeons, we are fortunate to practice in an era where tools exist. But let me begin with a simple observation. Technology improves surgery, judgment completes it, and sometimes the eye in front of us quietly reminds us of that. So the question I want to explore today is not about technological superior, please excuse my fumbling tongue, I don't have any teeth now. It is about surgical suitability.
We'll get in touch.
My question is simple. Is SICS optimum for hard cataracts? And my answer based on years of surgical experience and outcomes is yes. In many of the hardest cataracts we encounter, it remains one of the most dependable operations we can perform. When cataracts are mild or moderate, Finecy works beautifully. Phacoemulsification shines in these situations. The nucleus divides predictably, ultrasonic energy remains modest, and the procedure flows with elegance. Flax can further enhance the early steps of surgery by providing beautifully centered capsulotomies and initial nuclear fragmentation. In such cases, the technology works exactly as intended, but not every cataract arrives in our clinics at that stage. There are eyes where time has done its fullest work. The nucleus becomes dense, brunescent, sometimes almost stone-like. Every surgeon here has encountered such a lens, the kind that makes you look at the microscope, then at the phaco machine, and quietly increase the power settings. Or as some surgeons jokingly say, when the nucleus looks back at you with confidence, in those eyes, the dynamics of surgery change. The eye is no longer asking to be persuaded gently. It is asking for certainty. Hard cataracts demand that. We begin by acknowledging reality because one truth in cataract surgery is very simple. Not every nucleus reads the textbook. SICS begins with a different assumption. It respects the strength of the nucleus rather than denying it. Instead of assuming the load will be light, it prepares for weight and removes that weight in a controlled and decisive manner. There are moments in surgery when elegance alone is not wisdom. There are moments when controlled strength applied thoughtfully becomes the safer path. A very dense nucleus is not always something that should be endlessly negotiated with inside the eye. Sometimes it is something that should be managed confidently, brought forward, and removed intact. What I emphasize to trainees in this, SICS adapts itself to the eye rather than forcing the eye to adapt to a machine. The scleral tunnel is deliberate The architecture is stable and the pathway for the nucleus delivery is secure. What ultimately leaves the eye is not a prolonged sequence of fragments, but the nucleus itself resolved in a single decisive step. And this matters because one factor in cataract surgery is often underestimated: time inside the eye. In extremely hard cataracts, prolonged phacoemulsification carries a quiet cumulative cost. Ultrasonic energy increases, fluidics become more active, manipulation becomes more demanding. Can certainly assist by segmenting the nucleus before phaco begins. But when the nucleus is extremely dense, even laser fragmentation cannot eliminate the fundamental mechanical resistance of the lens. And the longer that resistance is negotiated inside the anterior chamber, the more the corneal endothelium quietly absorbs the consequences. The cornea may appear beautifully clear on the very first post-op day, but the endothelium remembers every extra second, every extra pulse of energy. SICS approaches the problem differently. It shortens the internal struggle. It moves the dense nucleus with minimal intraocular energy. We often associate smaller incisions with kinder surgery, and in many situations, that association is correct. But kindness in surgery is not defined as by the incision size alone. Stability is kindness. A well-constructed scleral tunnel maintains intraocular pressure beautifully throughout the surgery. The chamber remains stable, the eye remains calm, and the surgeon remains fully in control of the environment inside the eye. The eye does not fear a planned opening. What it fears is instability. From a practical standpoint, SICS offers something extremely valuable when dealing with dense nuclei: predictability in situations where unpredictability is high. When the nucleus refuses to crack, when the chopping becomes difficult, when vacuum behaves unpredictably, or when emulsification begins to feel longer than it should be, SICS provides a clear pathway forward, not as a rescue maneuver, but as a deliberate surgical strategy. And this reliability is not theoretical. Across decades and across continents, surgeons have restored sight to millions of patients with very dense cataracts using SICS. There are often the most advanced cataracts we encounter: late presentations, mature lenses, brunescent nuclei, yet the outcome remains excellent. Another aspect I would like to highlight here, particularly in an instructional course, is independence. Technology is remarkably allied in modern surgery, but every surgeon here has experienced the moment when technology hesitates, machines pause, vacuum behaves unexpectedly, power fluctuations appear at inconvenient times. Phacoemulsification and flax depend on sophisticated systems functioning perfectly. SICS depends primarily on trained hands and sound judgment. It does not stop when technology pauses. That independence is not a limitation, it is resilience. And resilience matter greatly in the world we practice in. A technique that restores vision safely without independence on expensive infrastructure carries responsibility beyond individual preference. It travels well, it serves district hospitals, it serves outreach programs, it serves high volume centers where the burden of advanced cataract is greatest. Vision restored there is no less meaningful than vision restored in the most technologically advanced theater. For patients, priority remains remarkable, consistent. They want clear vision, safe surgery, predictable outcomes, and often affordability. SICS meets these expectations remarkably well. It does not discriminate between urban and rural practice environments. It works wherever skilled hands exist. Let me say this very clearly. This is not an argument against phacoemulsification, and it is certainly not an argument against flax. Both represent extraordinary progress in cataract surgery. This is an argument for judgment, because ultimately the question in surgery is not which technology is newer. The real question is which approach is right for this eye. Mastery in surgery is not uniformity, mastery is discernment. Phaco is outstanding where finesse is rewarded. Flax offers remarkable precision and reproducibility in selected cases. But when the nucleus becomes extremely dense and resistant, the goals shift slightly. In such cases, completion with safety becomes more important than prolonged persuasion. As instructors, our responsibility is not to teach what is technologically impressive. Our responsibility is to teach what is faithful to the eye in front of us. SICS reminds us of some very important surgical principles. Respect the cataract that exists, maintain stability within the eye, minimize unnecessary intraocular stress, and complete the procedure decisively. In the hardest cataracts, SICS offers a shorter internal struggle, predictable mechanical control, protection of the cornea and endothelium, independence from complex machinery, and consistent outcomes across diverse clinical settings. This is not a step backward in surgical evolution. It is standing firmly where ground remains solid. So when the cataract is at its hardest, when the nucleus no longer yields easily to fragmentation, when the eye asks not for persuasion, for certainty, I choose the operation that finishes the task calmly, protects the eye faithfully, and restores the sight with confidence. And that is why, even in a course devoted to conquering hard cataracts with phacoemulsification, SICS remains optimum for hard cataracts, not as a technique of the past, but as a reminder that the best technology in cataract surgery is still the surgeon's judgment. Thank you.
Sir, and I think you summed it up, or like in words that no one can argue against. That everything said and done, yes, you have technologies, but they're all working around the limitations or the challenges that they exist as solutions for hard cataract, and they exist as solutions for challenges you face when you're doing phacoemulsification. With SICS, none of those exist. And I think that's why it's very important as a surgeon that if you see a case, choose the path that will be least stressful for you as a surgeon and the patient. There is no glory in saying, oh, I can do phaco in any kind of cataract, but there is a lot of pride and glory in saying I do what is in the best interest of my patients. SICS is still an incredibly elegant solution for the hardest of cataracts. I could make a case that you can actually combine MyLoop with SICS, make the incision even smaller. But for cases where, especially when you are beginning, when you're still, let's say, not very comfortable with phacoemulsification, SICS is the way to go. If you have any two doubts about it, SICS.
And I would just like to add one last word. You must have seen that last video, 3 minutes 46 seconds. Wasn't it bizarre? But that's how we've been doing it throughout our lives.
True.
Thank you.
Yeah. Thank you so much. Any questions? And thank you so much for being here on the last day as everybody is heading home. But I think, hard cataracts are something that challenge us. And I think as a surgeon, what I always teach my residents is there's no one right way. There are different ways. Each surgeon, something will perform better than other techniques in their particular hands, and I think it's important to understand that. to know your strengths and definitely your limitations also, and always act in the best interest of the patient. Thank you so much.